in the germline BRCA mutation group, there was a hazard ratio of 0.27 in favor of use of niraparib. And then in the germline BRCA mutation, there was also a very statistically significantly positive hazard ratio as well. I can't remember the exact number at this point, but it was very positive. The exploratory endpoints of that trial were to look within that germline negative group and try and characterize them further. And that was actually presented in the main presentation, where they found patients with somatic BRCA mutations and actually small numbers, which we expect. But in that small group of patients, their hazard ratio was almost identical, if not identical, to that of the germline BRCA mutation patients. So they seem to gain the same degree of benefit from use of niraparib as did their germline BRCA counterparts. And then there were subgroups that looked at patients who had something called homologous recombination deficiency, and this was measured by the Myriad test. And basically what that means is that there's evidence in the tumor that tumor at some point in the life cycle of that patient had difficulty repairing double-stranded DNA breaks. It doesn't tell you why that is or whether or not that status is still present, but it tells you that tumor, at least at some point, couldn't fix itself, it couldn't fix its DNA. And so they divided patients into what we call HRD positive, excluding those somatic BRCA patients who are certainly HRD positive. So they were analyzed separately. They were analyzed together and separately, but they pulled those guys out. And then the HRD negative patients. And really the surprising thing, I think, to everyone was that both groups benefited significantly. So you wouldn't have really expected the HRD negative group to benefit, but they had a statistically significant improvement in their PFS by virtue of a hazard ratio that was 0.56 or 0.58.